Last week, actress Oliva Munn revealed she was diagnosed with breast cancer and underwent a double mastectomy last year. Now, this happened after the 43-year-old's doctor calculated her breast cancer risk assessment score. Her lifetime risk was 37%, so she got an MRI, which led to an ultrasound and a biopsy. Well, that biopsy revealed Munn had an aggressive cancer called Luminal B in both of her breasts. Now, here to talk about this in studio is Dr. Heather King, a breast surgical oncologist with Texas Breast Specialists, Austin, and Texas Oncology. Thank you so much for being here.
Thank you for having me.
Dr. King, one thing that stood out to me about Oliva Munn's story is just a few months prior to her diagnosis, she had a clean mammogram. Would you explain how this important screening can miss something?
Well, it's important to understand that mammograms are baseline imaging for women of average risk to screen for breast cancer. It is the most effective way, and we have 30 years of prospective data showing that it reduces the risk of dying from breast cancer by 35%. But she had a strong family history and had undergone genetic testing, which was negative, which then prompted the risk assessment, which then showed that she was still high risk, which then prompted the MRI. And so women who are of average risk, most mammograms, and certainly with 3D mammograms, which are widely available now, mammography will capture most breast cancers.
Now, what is the breast cancer risk assessment tool that she talked about, and who should be given this? Should it be given prior to the first mammogram?
Most people do fill out some sort of intake form when they're going in for the mammogram, and that acts as a screening to signify to the physician, hey, maybe this patient meets criteria for genetic testing, they have family history, maybe there's some other things here. It's not clear. It's important to understand there are multiple different statistical models, and so when she said breast cancer assessment tool, to me there are at least 5 models that could have been used. I actually, in my office, we use the Tyrer-Cuzick model, which is shown to be the best model in prospective trials versus some of the other models that are out there. So I'm not sure which one she was used to calculate her risk, but that's the one that we typically use in our office.
Going back to the gold standard of screening, women who are at average risk for breast cancer are recommended to get annual mammograms starting at age 40. What are some other screening methods and guidelines for certain women, those with dense breast tissue, breast implants, or family history, for example?
So you should always talk to your physician. These risk assessment tools are always available. You can certainly come see a breast specialist. We in our practice are happy to do this and help sort out what's going to be the best imaging. For most women, we're going to start with a mammogram, and then there are supplemental imaging techniques. Ultrasound can be used in women who have dense breast tissue to supplement the mammogram. We don't want to jump to MRI because it can be overly sensitive and pick up things in the breast that are actually not breast cancer. And then you've caused a lot of anxiety, unnecessary biopsies. So all of these imaging modalities are complementary to each other and should be used in specific situations. I try to tell patients the mammogram's kind of the roadmap to the breast. We start there, we layer ultrasound, we layer MRI. There's even a contrast enhanced mammogram, which is a newer technology, which is really neat as well. So you have to talk to your physician, and your baseline mammogram will also tell you whether or not you really do have dense breasts, because sometimes women are like, my breasts are lumpy, they're dense, and then sometimes they're not on imaging, which is great.
Right. Let's talk about luminal B cancer, which is what Oliva Munn was diagnosed with. What is that? How is it treated? What is the prognosis?
So there's basically 4 general subtypes of breast cancer. Luminal A and luminal B are breast cancers when we do our first run of testing on the tumor to define what it's going to respond to, what medications should be used, and generally how it will behave. Luminal A and B show estrogen receptor positivity. Luminal Bs will, even though the estrogen receptor is positive on the cancer, meaning the cancer cells have maintained this receptor, It doesn't mean the growth of the cancer is relying on estrogen, and if you starve that cancer cell of estrogen, it may not treat it. So they're more aggressive, they can grow more rapidly, and therefore chemotherapy can be needed because it can be more effective for this type of breast cancer.
All right, we are out of time. Dr. King with Texas Oncology, thank you so much for sharing your time and your expertise with us tonight.
Thank you so much.